Doctora Regina, su micrófono está ya está.
Yeah.
Muy bien. El lujo. Okay, so we're live. There are more participants joining us. So welcome everyone. My name is Elena Blacaller and I am co-founder at Pagomet. This is an initiative called Pagomet Talks, and today I'm really excited because we have 5 experts from Mexico and the United States. 3 of them work at the Massachusetts General Hospital, and they'll be sharing with us some of their experiences with COVID-19. Right now, Dr. Katarina Ruscic will be our moderator, and she'll be guiding us through some questions and some things which I'm sure we all want to know about this disease. So welcome everyone. Thank you for being here.
Thank you.
I'm so excited that we could all come together today to discuss the various experiences we've had with COVID-19. And I just wanted to start by having each of our speakers tell us a couple of lines about themselves. So what specialty in medicine are you? What country are you practicing in, and what setting? And so can we please have Dr. Rodriguez Arias start?
Okay. Español, inglés.
English. We have people from everywhere looking at this.
Por eso pregunto. Okay, hi everybody. Thank you very much for the invitation. I'm very happy to join here. So I'm anesthesia. I did anesthesia at the Universidad of Guadalajara. Now I'm working at the Civil Hospital of Guadalajara. I have a subspecialty in neuroanesthesia, and I also have which I did in the National Institute of Neurology and Neurosurgery. And also I have a fellowship in neurocritical care, which I did at St. Michael's Hospital and the University of Toronto. And now I'm usually in the OR or in the neurocritical care unit. But right now with this pandemic team, I'm working at the COVID unit in the civil hospital. I'm the chief of the leader of the airway team.
Awesome, thank you. Next, can we have Dr. Ville introduce himself?
Yes, of course, thank you. My name is Dr. Rodrigo Ville. I am from Guadalajara also, but I studied internal medicine and infectious diseases in Mexico City. At the moment, I am working at a new field hospital. This is a brand new COVID-19 temporary unit with over 850 beds. So I am one of the clinical leaders here at this new unit, and I'm very grateful for the invitation of being here.
Thank you. Next, Dr. Kenneth Shelton.
Hi, I'm Ken Shelton. I'm a cardiac anesthesiologist and the medical director of the Heart Center ICU here at Mass General Hospital. We cover 34 critical care beds, and it's a 1,000-bed hospital. And a lot of our work within the Heart Center has been on patients as part of the shock team with extracorporeal membrane oxygenation, so VA and VV ECMO support. And we support all of the VA ECMO patients in our Heart Center.
And Dr. Bittner.
Yes, hello. I'm Ed Bittner. I am an anesthesiologist and critical care physician at Mass General as well. I'm also the director for the Critical Care Fellowship. And over the last, almost 3 months now, I have been involved in primarily in the ICU and a number of our ICUs taking care of COVID patients.
Great. And I'm Dr. Katarina Ruscic. I'm also faculty at Massachusetts General Hospital with a specialty in anesthesiology and critical care, and I'll be helping lead the discussion. So I just wanted to start with Dr. Rodriguez Arias. Can you just tell us a little bit about both your experiences in the operating room and in the ICU in terms of what number of patients you've been seeing, how sick have they been, and sort of overall impressions of what you've been experiencing.
Okay, well, our hospital is a non-COVID-19 designated one. So we only have like a small unit for contention. This unit has 30 beds, of which 10 of them are ICU beds. So we have 24 20 beds in the ward for hospitalized patients. They are classified in non-symptomatic and symptomatic, like in 2 different wards. And well, that's it. Patients that are being admitted here are very sick, most of them. I think we're not doing very bad with the ones that are in the ward, but the ones that get to ICU, they're not going very well. I'm not involved as much with attending those patients. I'm most in the airway team, so like anytime we need, they need to intubate a patient or to exchange a tube or anything that is related to airway management, that's when me and my team get involved. And in the OR, we have like 1 or 2 designated operating rooms for COVID patients. So at the beginning, the plan was that if we have a COVID positive patient that needed some kind of elective surgery, that patient was going to be transferred to the new civil hospital, which is the one that is supposed to be full converted to COVID, for COVID patients. But given all the circumstances, we have to habilitate 2 ORs for some kind of electives or urgent or emergency surgeries for COVID patients.
One question, when you say the new hospital,
because here in Guadalajara, we have 2 civil hospitals. So the one that I'm working at, it's called the old one, sorry. And the other one is the new one. That's it.
So more recent than the old one, but not new since the pandemic.
No. It's just the way that people get to know those hospitals.
Yeah. Dr. Ville, will you tell us about your experiences in the field hospital and how that even came to be?
Yes, of course. So this is a brand new hospital, which was built over a convention center. It's the same concept that was used in China with the Fankang shelter and hospitals, and the same concept that the Spanish used at the IFEMA Center. So this hospital was actually built in only 10 days at this big, large convention center in Mexico City. And we started operations about 5 weeks ago. So it was born because of the union of the private sector and the public sector. So they both put the money and the funding to create this. So the hospital is divided in 3 wings. So far we have only started operations on wing A because of the needs of the city. But we have the capacity to start using wing B and wing C as soon as the city needs these beds. So overall, we have around 850 general ward beds for moderate to mild cases, COVID-19 cases. And we have also 3 intensive care units, each one on each of those wings. At this moment,
so the ICU is also in the field hospital?
Yes. So in this moment, it's not a proper ICU per se. It's what we call the advanced respiratory therapy unit. For example, we have 8 beds at this advanced respiratory therapy unit, but we don't have 8 ventilators. We only have 6 ventilators. So we have monitors, we have high flow nasal cannulas, we have some ventilators, but not all of our beds have ventilators. This is due to a global scarcity of ventilators, but we have the capacity to to buy some more and to train people to start using them.
A question to both Dr. Ville and Dr. Rodriguez Arias. When did you start seeing an influx of COVID-19 patients? Around what date did you start kind of seeing that, okay, we're starting to, this is real, we're getting a lot of these kind of patients here?
Okay, Doctora?
Okay, well, here in Guadalajara, it's been lately, like we started noticing the peak like around 2 weeks. Before that, I moved from the OR to the COVID unit like the end of March to set up all the protocols and everything. And we have some patients, but these last 2 weeks has been crazy. I think it's not as bad as Mexico City, but we are going in that way.
Yeah.
And Dr. Ville, of those 850 beds that you have available, how many of them are actually occupied right now?
We have about 110 patients at this moment, but the most patients we had was 150, around 150 patients at a certain moment. And that happened about 1.5 weeks ago. The first cases in Mexico City were detected on February the 28th. After that, we had about 2 weeks of non-community spread, non-communitary spread of the disease. But after that, community cases started to arise. And since that time, we have been seeing cases every time more and more and more. So for us, the time where we had more patients was around 3 to 4 weeks ago. And that stopped and it came to a flat state. But now, today, cases are starting to come over again. So we are actually starting to train people to start opening the next wing, probably around next week. So we are expecting to receive more cases around next week.
Wow. And tell us, what's determining who needs a bed in the field hospital versus who, okay, they probably have COVID-19 or maybe they've tested positive, but this person we send home and have them monitor their own symptoms versus deciding this person actually needs a bed in your field hospital?
Okay, probably, as you know, in first world countries, or developed countries, people who go home have the capacity to buy an oximeter, a pulse oximeter. They have the capacity to have cell phones and proper telephone or telemedicine follow-up. Here in Mexico City, a lot of people can't go home. And if they go home, they cannot isolate properly inside their home. They live with a lot of people. So this hospital works not only as a hospital, but also as a shelter, a voluntary shelter for people who have a positive test, even if they are asymptomatic. So these people can be admitted to the hospital. The other thing we do is we have very, very strict criteria, because since we don't have a lot of ventilators, we have to be very careful in order to avoid people getting sick or sicker. If they develop a severe COVID-19, we don't have ventilators to treat them, and there are no beds in the city to take them. So we have to be very, very strict. Our criteria include the COL score, which was developed by the Chinese. We also use a Mexican score, which is called the ABCD Goals score, which is a score that predicts mortality and ICU and the need for ICU in COVID-19. And we also use the NEWS score. So basically, those people who have a low risk to disease progression or death are the ones that are being treated at this center right now. If we wanted to increase our criteria, we should have a proper intensive care unit with more ventilators. At the time that we accomplish that, our criteria will be able to expand. And the same thing happened in other field hospitals. The same thing happened at the IFEMA Center in Spain. So we are expecting to increase our ventilator capacity in order to also increase our admission criteria for this center.
interesting. I will actually circle back to all of our speakers and ask questions about, in your various practice locations, what has been the trigger for intubation or transfer to the ICU, and perhaps how that's differed between our two centers. Dr. Bittner, can you speak to what the experience has been like in the MGH ICUs, the acuity, how many numbers we've been seeing, impressions in general?
Sure. So we started getting COVID patients in early March and hit our peak around mid-April. So I think it was around the 19th. At that point, we had 340 COVID positive patients in our hospital. We had 150 plus patients with COVID in our ICUs. And went through a plateau period and now have come down substantially, so that at least as of 2 days ago, we only had 34 patients remaining in the ICU and 100 patients in the hospital with COVID overall. I think you had asked about, did you ask about our sort of criteria for intubation as well, or?
Sure, yeah, go ahead and speak to that.
Okay. So a couple things. One, you know, we're fortunate, you know, that we have 10 ICUs and it sounds like, you know, considerably more resources in terms of ventilators and so forth. But even then, we were certainly concerned that we were going to run out of resources. But there were a couple of criteria that were different for us. One was that we were very concerned about the risk of aerosolization of virus with the use of non-invasive ventilation or with the use of high flow nasal cannula. And because we did have a greater supply of ventilators, we had a much lower threshold to intubate patients. There was also a belief that by intubating patients earlier, we might result in less self-induced lung injury, and that ultimately outcomes might be better. I think, you know, over the course of the time that we've been taking care of these patients, our ideas have changed, but at least that was our initial practice.
Yeah. Before I jump to Dr. Shelton, can I ask Drs. Ville and Rodriguez Arias how the criteria for intubation and or ICU are perhaps similar or different for you?
Okay, sorry. Well, here, maybe at the beginning, we were trying to do like early intubation. This was decided by the ICU team or the infectious disease team, actually. As an airway team, we are not like the ones that decide when to intubate a patient or no.
And when you say early, how early? Like, were they just on a few liters of nasal cannula, or what did they look like when you say they were early intubation?
No. We always at the big, that's always, we first of all try or give a chance with high flow nasal cannula. And then if they are not getting to the targets, we intubate. Like we did that earlier before, but now we are doing more like conscious patients, and I think the outcome is a little better. I think we have like avoided some intubations that in the past, like maybe a month ago, we would have intubated like without no hesitation. And now I think we are seeing that these patients are giving like more time gain more chance with the high flow nasal cannula in the prone position, maybe they can avoid the ventilation. But anyway.
What about CPAP or BiPAP as well?
Yeah, so yeah, sometimes if the high flow nasal cannula is not enough, they give a trial of CPAP or non-invasive ventilation. And for that, they move the patient to the ICU because of the aerosol thing. But anyway, here, so protocol is planned. It's the ICU team and the infectious disease team, the ones who are deciding when to intubate a patient.
And since you have had the experience of using high flow nasal cannula and CPAP, BiPAP, in the hospital, have you seen any resistance or protesting by providers that should we be using these modalities, should we not, because of the aerosolization risk to providers? Or did was everybody on the same page that this is the way to go?
No, I think we are on the same page because we have like all the personal protective equipment. So like there's no hesitation about that. And I think since the beginning, we spoke as a team about that. And I think some of the people like are not working in the COVID era are more hesitating about these things or are more reluctant to this. But here, I don't think so.
And in terms of once those patients reach that modality, they have to be in the ICU. Is that because the rooms in the ICU have negative pressure, or just sort of like a more controlled environment, or what's
it's
the
more
thought?
like a controlled environment because we don't have, unfortunately, negative pressure and like the things that you have in a very developed country. So we move patients to ICU because of it's a more controlled environment and because people in the ICU have like the full PPE. So that's the reason. But we don't have negative pressure rooms here. This is a public hospital, so no.
And Dr. Ville, tell us about in the field hospital. Are you guys also, for the non-ICU patient, or perhaps also for the ICU patients, are you using high flow nasal cannula, CPAP, BiPAP?
Yes, so we had to create internal protocols from scratch. So this hospital didn't exist 6 weeks ago. So we had to create those protocols. And in those protocols, we evaluate every patient and we classify them by colors, green, yellow, and red, according to some laboratory data, image data, and according to their clinical status. So those patients who are green or yellow, they don't require an intensive care specialist evaluation. But those patients who are red, even if they are in the general ward, they always require an intensive care unit specialist evaluation. So it's the intensive care unit specialist who decides, according to also some internal protocols, which patient is going to be intubated versus who are not. We usually practice awake proning. It's usually our first maneuver, awake proning, because for us, people who need high flow nasal cannula have to be moved to the intensive care unit because people in the intensive care unit need to use full PPE, and people outside the intensive care unit don't have the full PPE. So if we are going to administer high flow nasal cannula, it's got to be a decision made both by the infectious diseases specialist and the intensive care unit specialist. And that's the first step. After that, they use the ROX score to try to predict the patients who will eventually need intubation. And according to this score, they practice intubation. So that's how we are doing things here. But the interesting phenomena we are seeing is that our patients are so well chosen to get into this hospital that we don't have a lot of intubated patients. We actually don't have many of them. The people we are intubating are the ones that get really sick during their transfer from other hospitals. During transportation, they get sick and they usually come to the hospital and get intubated right away. So it's a very interesting phenomena we are seeing.
So those people that you are in a sort of watch and wait modality where they're not super sick, but you don't want to send them home because they don't have a pulse oximeter, you're not
Yes.
seeing a huge number of them crashing and needing to be intubated.
No, actually no, because according to our selection criteria, they have a low risk to progression, and that's the exact way they are behaving. So they usually don't get really sick and don't get severe disease. So yes, we are watching them, following them, giving just general care, and that's how they deal with the disease.
And tell us, what are some of the features that you think are consistent with low risk versus the high risk that are more likely to go to?
Okay, you know, age, those who are younger than 65 years old, hypertension, diabetes, uncontrolled hypertension and uncontrolled diabetes, obesity. Obesity is a main health problem, public health problem in Mexico City, especially for younger people. So we try to choose patients who are not really obese, people who have active cancer. Those kind of people may not be the ideal candidates to get into this hospital. So the majority of our patients are mild to moderate COVID-19 cases. We also use laboratory data like D-dimer, C-reactive protein, lymphocyte, neutrophil count, lactate dehydrogenase, and of course the arterial gases. So we use all of this information to calculate the risk of severe disease. And if a patient has severe disease, it is better for them to stay at the other hospitals in the city, which have proper capacity to, you know, take care of them.
Interesting. That makes sense.
Yes.
Dr. Shelton, you have seen some of the sickest of the sick that are so sick they've developed rare cardiac complications and need super advanced therapies. Tell us about what you've been seeing, your overall impressions, and what some of these more cardiac oriented patients look like.
Absolutely. So one of the things that we had to change right away was how we think about the number of patients coming in. So as I think Dr. Bittner mentioned, when you have 150 intubated patients, some of them are going to reach criteria for needing extracorporeal membrane oxygenation. So I think you have to then decide of those sick patients that are failing the ventilator, which ones do you decide to put on advanced mechanical circulatory support. And so essentially what we were forced to do was create a 4-attending review panel with new criteria under kind of our hospital incident command system to decide which patients we would then accept as candidates for advanced therapies. We've had over 100 consultations so far. We've placed 20 patients on ECMO. And it's interesting in that of all of the patients, most of them, although we had some very early cardiac myocarditis type of patients, the majority of them seem to have isolated pulmonary pathology, ARDS physiology, and seem to be well supported on VV ECMO. Certainly we've had a few that interestingly enough seem to have isolated myocarditis and in profound cardiogenic shock, but without significant respiratory pathology, which is, I think, quite fascinating. And I think it tells us a little bit about the virus itself and how it behaves in each patient. And then we've had a couple pediatric patients too, as I'm sure you've heard, this new inflammatory process that's come up. We had one teenager and then one young patient in the PICU, both supported on VA ECMO for myocarditis, an inflammatory cardiogenic shock picture.
And for these super sick patients that end up needing mechanical support, what's their survival rate so far?
Yeah, it's a phenomenal question. So I think early on with very strict criteria, again, we had a cutoff based on age, BMI, obviously major things that existed in the old criteria, active malignancy, stroke, that kind of thing. We also set the age limit pretty low. We ensured they didn't have other multi-organ issues. And so the patients that we were putting on in the very beginning of the pandemic were actually doing quite well. We had many were in their 40s and 50s. And at that point, I'd say halfway through the pandemic, the survival was about 50%. A fair number of them were coming off of the circuit. I think later on in the pandemic, because at one point we had just 3 patients on ECMO when we were really peaking. We liberalized the criteria and we started accepting patients that were older, some extending our current BMI criteria. And I think with that, what we found is our about a third of the patients were able to come off the circuit, about a third expired, and then a third are currently still on VV ECMO. So I think one of the lessons we learned is that similar to the ECMO experience before COVID, if you extend the criteria and you start putting patients on that have more multi-organ issues, I think what you'll discover is the mortality will probably look pretty similar to kind of pre-COVID ECMO criteria for ARDS. That was certainly the case here.
Wow. Dr. Rodriguez, can you tell us about what it has felt like for you to intubate these COVID patients? Or if you could kind of take us through a scenario of what it looks like when you, I don't know if you guys carry pagers and you get a page up until when you or your team arrives to the bedside, what the setup looks like, what the PPE looks like, and how it feels to intubate these patients. Do they decompensate while you're intubating them? What does the whole, paint us a picture of what it looks like.
Well, now you're asking me something of my field. So, well, we also created a protocol for the COVID unit. Like there's always a staff physician, an anesthetist staff physician here with a resident, usually PGY3 of anesthesia, of course. So we have like an airway box, like an airway trolley, I mean, with all the equipment for intubation. We have there like all sizes of tubes, LMAs, Gettle cannulas, everything, boogies, etc. And we have also like a small box with all the medication that we could probably use during an induction, and even considering if the patient gets sick during or after the intubation. So we have two scenarios for intubating patients here in the COVID unit. One is like an emergency intubation from a patient that is just being admitted, like comes from the street, or it's just brought from the patient, by his family or something, and comes very sick with a lot of increased work of breathing or something. So they get in like to a triage, which is done by the infectious disease team, and then they transfer the patient to like a kind of emergency room for COVID, and that's the first scenario. There we have a small area with like a CPR, like a CPR trolley, and we have like the oxygen, the aspirator, and everything set up. So we get dressed with all our full PPE, and then
Tell us about what your full PPE looks like.
Like an astronaut. No, it's very hot. So we use like we have reusable respirators. That's the things we are using because they are more comfortable and long-term use. We use like, how how do you call it, like the white suit, the one with the hoodie, and also an extra gown, an impermeable one, 2 pairs of boots, 3 pairs of gloves, and I think that's it. Well, and of course the goggles, or they could be like, I have a full face mask, so I don't need like an extra shield, but my colleagues that only have the goggles, they use like an extra shield in front of them, and that's like our PPE. So, and the second scenario is the patient that is in the ICU with a high flow nasal cannula or with non-invasive ventilation, and the ICU team decides that it's not getting better, so the patient needs to get intubated. So the setup in the ICU is like the classical ICU setup with a lot of pumps and medications running and everything. And also we have the same kind of airway trolley, which we always are carry and bring it in. You know, in the ICU we have everything also, but we as the airway team are more used to some other settings, so we always bring our airway box. And the thing here, a very interesting thing that I want to mention, it's I think you have heard or you have seen in the social media the use of the aerosol box. I think this get very, I don't know, it was very popular because of the social media, and then a lot of people that wanted to help started creating different versions, like new generations of these aerosol box, and they started donating a lot of aerosol box in different sizes, built of different materials, because I guess they were very well intentioned, but we are not using the the box. I think something that people miss when speaking about the box and when trying to build different kind of aerosol boxes, it was that the paramount thing for intubation a patient, what is considered one of the highest risk procedures with a COVID patient, is that the paramount thing is the full PPE. You don't need a box, you don't need anything else if you have full PPE. And that's the thing, that's the issue. And also we as airway experts, the management of these patients for intubations has to be with a modified rapid sequence induction or intubation, used to minimize or to reduce the aerosol that could be generated or that could be free like to the environment. This intended to like reducing the risk of contamination or getting infected, you know. But the thing with the box is that when you are doing modified rapid sequence induction, you have to give your best shot. You have to intubate in the less time that you can. You have to get to success in the first attempt if it's possible. And the box, these difficulties a lot. Even we were doing a lot of simulation here, and the box like kind of doubles the time for a successful intubation. And also the box sometimes when you use all your full PPE, it can sometimes tear or breach the PPE, which puts you into a big risk of contamination or infection. And also it's very complicated to maneuver, to give all the maneuvers inside the box. You know, when you're intubating one of these patients or these kind of patients, aerosol is gonna be generated in some way, no matter what you do. The thing is that you need to reduce the aerosol that it's maybe that gets I don't know into the environment. So what we started doing here, like a plus to our full PPE, is using a plastic drape. but the plastic drape not the same as was described by Dr. Mataba of Sick Kids, which was the one that I think came out with this good idea. So within the extra gown, the one that it's impermeable, we fix with medical tape or plastic drape, which with a lot of simulation, we get to the conclusion like the best size of that wasn't like 1 meter per 1 meter. We used one of 2 meters from side to side, and like 1.3 meters from the head to the feet of the patient, let's say that way. So we fixed that with tape in the chest, like 10 centimeters around of the sternal notch, and from medial, from the clavicle, the medial clavicular line, I think. That's the way we fix it. And then we cover the patient. And after intubating with video laryngoscopy, when we are okay with the intubation, like the second operator, which is the second anesthesiologist that is helping the one that is intubating, pulls off the tape and takes the plastic drape very carefully from the center to the periphery in a way to not generate more aerosol. And this allows that the aerosol that was like kind of encapsulated, if I can say that way, in the small environment between the patient and my gown, settle this down. So, you know, when you are like all the droplets and the small aerosols or whatever you want to call them, can stand like floating, let's say that way, in the environment. With the plastic drape, you can push them down in some way, in a slowly manner, and then you can dispose it. So the thing with the box is also that you have a lot of inconvenience for disposing the box, for cleaning the box, sanitizing the box, and the life of the box. So that's the way we are doing this. Most of them with video laryngoscopy, but when you are using video laryngoscopy, you always have to have a backup of a regular laryngoscope in case of the battery or the light or whatever. So the plastic drape that is attached to us with a tape, it allows you to manipulate very well the head of the patient and to get closer to the mouth of the patient, but with this extra shield, let's say that way, and it allows you to move and to see, because when you're doing like a direct laryngoscopy, if you have a box, it depends on the size of the box, the size of the patient, like your whole personal constitution, how tall you are. That's gonna affect the angle of your vision to do all the maneuvers. And the box, you're gonna hit the box with your mask, you're gonna hit the box with your goggles, so it's very difficult. And the drape attached to the chest, you can always, the vision is not altered any moment, and you can move your angle of vision to do a successful intervention in the first attempt.
Doctora Rodriguez Arias, what a phenomenal description. Some more questions for you about this experience. So, as you've described it, you put on a spacesuit, and it sounds like this drape setup takes some time to figure out. So I'm assuming that they're trying to call you to intubate patients before they're really desaturating and doing badly. It sounds like it takes a few minutes to get all this set up.
It takes a lot of time, because we use a drape as an extra part of our PPE. So after I pull my PPE, I just take the drape. That's it. So
how many minutes would you say it takes from they call you, you're at the bedside, now you have to get all your stuff on and get set up?
No, we get the PPE before entering the ICU unit or before entering to the COVID emergency room, because we need to get in as soon as we get all the protection. Because, you know, there are no emergencies when there's in this pandemic setting. There are no emergencies, because it maybe is gonna sound weird, but we need to get protected before getting into the patient. But our team, we are getting dressed around in 3 or 4 minutes, including the drape, and that's the time it takes to get into the bedside.
So now you're at the bedside, you've given all your rapid sequence induction drugs, patient's asleep, you're about to intubate. How quickly are they desaturating?
Very quickly, very quickly. Sometimes when the patient comes, is just being admitted and it gets to our little emergency room, we do peroxygenation like with a facial mask. But when we are in the ICU, you know that the patients has already have a trial of high nasal flow cannula, or maybe they are with the CPAP or non-invasive ventilation. So what we do in that scenario is that usually they are already with the highest settings of the modality in which the patient is in that time. So we give like 5 minutes of peroxygenation. And then after that, we go with the drugs for the induction, and we give exactly 1 minute after the neuromuscular blockade, and the saturation goes down very quick. Like sometimes with the peroxygenation, you can get as high as 60, sometimes 55, and it's like, oh my God, he's doing very well. And after that minute with the apnea, we sometimes are intubating with 30, 25%, but that's the way these very, very, very sick patients behave.
So given the acuity of this, but also the need for everybody to have so much PPE, how many people are in that room to help you? It's you, and who else is in the room with you?
Only two. So if in the ICU, it's like the ICU staff. So they already have the full PPE because they spend more time than us in the ICU. If in the emergency room, there's only 2 people. So our protocol says that there have to be 2 operators for intubating a patient. The one that is intubated, which is supposed to be the one that has more expertise or more experienced one for intubating, and the second one, which is preferred to be an anesthesiologist also, who gives the induction and help you to giving you the things with the setup. And the thing with the drape is that the second operator helps sometimes giving some maneuver with the drape, maybe moving it to one side to another and taking care of you so you don't lose like all the protection. So trying to encapsulate the aerosol between you and the patient, and that exposing less to the people that is around. If it's in the ICU, as I said, everyone has full PPE, but if it's in the emergency room, we get in, we close the door, we do
so it sounds like it's basically you and your resident doing this.
Yeah, that's it.
Amazing. A question now for Doctors Shelton and Bittner from the ICU setting. So in the very beginning of the pandemic, everyone was talking about how this is really an isolated severe respiratory syndrome. Dr. Shelton, you've already spoken to seeing some severe cardiac complications, and in pediatrics, a whole different spectrum of perhaps even vascular plus cardiac complications. So for both of you, tell us about what extrapulmonary issues you've been seeing in the critical care setting, and how that's sort of perhaps been surprising, maybe not so surprising, and how has that been to manage?
Go ahead, Ed.
Okay, sure. So I think you're absolutely right. Initially, we thought about COVID-19 as primarily a respiratory disease, but the reality is that the virus itself, either through direct injury or through the consequences of inflammation, really affects multiple organ systems. I think we now are realizing that it affects, virtually all organ systems, either through, again, it's viral invasion or inflammation, or, the effects of the systemic illness. And we have talked about the pulmonary manifestations and the cardiac manifestations. Increasingly now we're appreciating the effects on the neurologic system, and particularly when patients are recovering, a lot of the neurocognitive deficits that patients suffer from, and myopathy. A high proportion of the critically ill patients suffer from some degree of acute kidney injury and require renal replacement therapy. There are all the hematologic abnormalities early on, which can be, DIC-like, or later on can be thrombotic. We have come to appreciate gastrointestinal manifestations as well. High proportion of hypomotility syndromes and gastrointestinal ischemia. Even endocrine manifestations, a lot of insulin resistance, and thyroid dysfunction, and likely adrenal impairment. Moving on from there, even dermatologic manifestations that we had failed to appreciate. So it really is a multi-system, disease.
Dr. Shelton, given all of these multi-organ issues, and particularly the vascular issues, possible DIC, possible microthrombotic picture, have you and your team encountered particular issues with supporting people on mechanical devices, or is it maybe not been such a big issue?
Right, I think it's a phenomenal question. Just to kind of piggyback off what Dr. Bittner mentioned, I think one of the challenges here for us is that often when we're getting involved as an advanced shock team, the patients are well past being critically ill. And so these are patients that have multi-organ issues as secondary to critical illness. And so I think one of the challenges here is trying to discern, are these patients developing these complications because they are so sick, or is there something about this virus that's unique that's making them this sick? And one of the things that I think will be interesting, as we start to collect more data, is that we do have one single virus. So it's not as if these patients are coming in with a lot of other issues. It seems to be they're coming in with COVID, and they're developing all these complications secondary to COVID. With respect to issues on being supported on mechanical circulation, we've now teamed up with some members of the Penn group. And I think one of the things that popped up early on in our data set is that the patients, although being on low levels of heparin that we maintain for ECMO circuits, we've had a relatively high proportion of patients with intracranial hemorrhage. And so there does seem to be something, I think, Ed Bittner alluded to DIC, and that certainly we've seen clotting on the membrane, particularly on our VA ECMO patients, where you almost see active what looks like thrombosis at the same time. The patients seem to be bleeding. And so I think it's really challenging. One of the things that we're forced to do on ECMO is keep the flows up, particularly when they're on VA support. And so I think, particularly for us, it's a question every day of how soon can we get them off ECMO, because we don't have a lot of experience, truthfully, with these patients on ECMO, and we're seeing, big complications on these devices. So certainly, we're not running it as a head-to-head trial with ventilation. It's used as a rescue therapy when they fail the ventilator, and we try to get them off ECMO as soon as we can, recognizing that there are devastating complications on ECMO.
And Dr. Shelton, the patients that are in your unit on mechanical circulation, how many weeks, let's say in the beginning of the pandemic, with the very highly selected patients, how many weeks were they critically ill and or intubated, and then how long were they on support?
Yeah, I think it's a phenomenal question. So I'll tell you, from the start, our VA ECMO population was actually quite interesting. These are patients that came in profound cardiogenic shock, high lactate spills, kind of ice cold, and supported on mechanical circulation for 72 hours. You know, we're talking about 3-4 days with almost complete recovery in terms of ejection fraction and overall cardiac function, which is phenomenal given the fact that they're in near cardiac standstill at the time of cannulation. And I think that was quite surprising and obviously great for the patients. And so the patients that we've had on VA ECMO support have actually been the ones that have left the hospital. I think early on on the VV ECMO side, one of the things that we noticed, there were a couple of the younger patients that were in bad respiratory failure and they recovered quickly. I think what we're seeing now, the patients that have been on longer are often transfers from outside hospitals. And so they've already had, you know, a week on the ventilator. And so I think we're selecting now, and we're seeing patients that have been on for a while that may not have a chance of recovery. They end up on a circuit, and you know, the circuit is not necessarily a therapy, it's buying time. And so those patients may not recover. And so I think now we're seeing longer runs of mechanical support because we're seeing patients that have failed therapy at outside hospitals.
Do you have patients that are on ECMO and also renal replacement therapy?
Right. So that's a great question. And you know, one of the benefits of the ECMO support is that the blood is paracorporeal, so you can essentially splice in an ultrafiltration machine and use the flow of the ECMO circuit to support the renal replacement device. And so certainly it's done and it's common, right? Because the patients that you're seeing are quite sick. They need mechanical support. And so those are the patients often that also have acute kidney injury. They have, you know, liver hits, and they have other complications too. So absolutely, you can run both machines together actually with just through the ECMO circuit itself. It's a great question.
Can you tell us a little bit about what it felt like for you and for your team when you guys had your very first patient recover and was taken off of the circuit?
Right. Yeah, I think I'll tell you, you know, the first kind of shock patient that we had on the cardiac side was probably the most memorable, in that she was on her cell phone talking, and this was not at all what was being described in terms of failing ARDS patients. And so, you know, she wasn't prone, she wasn't intubated even, but she had an EF of 10%. You know, her husband had terrible ARDS secondary to COVID. And so it was shocking and it was frightening because she was in her 30s and she was very, very early on. I think this was one of the few cases that was described in New England. She was, I believe, the first case in New England. And so I think we were concerned, recognizing that we didn't know as much, I think, as we thought we did early on about COVID. And kind of, it would certainly take time before we started to see what this virus could do. Certainly, though, as she started to recover, I think it gave everyone hope. Because I think that was at a time when the numbers were going up. But I think as clinicians, we felt like, geez, this is someone that was that really would not have made it without the help of the team and having a good hospital support system and the nurses and the physicians. And so I think in a way, although the numbers were getting worse, I think the clinicians felt like there is something that we can do for these patients. And so I think if anything, it brought hope to the team providing care. And I think people, at that point, they didn't want to go home. You know, they wanted to stay and help and take extra call. And I think that's who we are as clinicians.
That's an amazing story for morale, and what a win for the patient and for your team. Dr. Ville, to bounce the question back to you. So we heard from Doctors Bittner and Shelton about some of these other non-pulmonary complications in the critically ill population. In the group of patients you have in the field hospital that are pre-critically ill, are you seeing any of these extra pulmonary complications, or is your sense that those also come later when the pulmonary issues come? Oh, we can't hear you.
Yes, sorry. Yes, we are also seeing some of these complications. For example, the endocrine complications, such as insulin resistance and hyponatremia and other complications, we are seeing them. And they are usually a sign that the patient will develop a severe COVID-19. And for example, we've seen some encephalitis and also thrombosis. So it is very obvious that this disease is a multi-systemic disease. We are having the exact same experience as you are having.
And Dr. Ville, how do you think field hospitals are going to evolve as the pandemic evolves, and over the next few months? What do you see happening on your front?
Yes, I think in places where field hospitals exist, they will be critical in containing the pandemic over the next months. Where peaks start to re-arise, I think they will be critical to stop the pandemic, the communitary spread of the disease. For example, in Spain, the IFEMA hospital, it is at this moment, it is put on hold, but they are waiting for the next peak, probably during the winter season, to start operations again. And because of all of the experience they have gained during the past few months, they will come back with better protocols, better, everything experience has given them. So I think field hospital will evolve from what we are now, which is a hospital seeing mild to moderate cases. They will evolve to a proper hospital. We have the protocols to be started as soon as we are needed, to be deployed as soon as the beds are needed. And that is something that will be very, very handy when cases start to arise again during the next wave of this pandemic.
Well, an hour has somehow already flown by. I have a million more questions I could ask all of you, because it's so clear that everyone's experience is so unique and so outside of what we usually experience day to day in our various hospitals. I wish one day in person we could all get together and have a chat. But I guess we'll draw this session to a close, and I'll give the floor back to Elena.
Thank you so much, Dr. Katarina. Before we end this, I'd like to make one question for the 5 of you. Which things would you have liked to know before the pandemic arrived to your country? I don't know if Dr. Katarina, would you like to answer?
That's a hard question. Maybe one of the more surprising things was we've learned on the fly that so many things, so many organ systems outside of the lungs were affected. And I found that surprising, because the mantra at the beginning was that it was all about the lungs. But if I can answer a second, I wish I have a crystal ball and know how many patients we were going to have total, and if we will see a second wave. That's what I wish to know.
Okay, good answer. Dr. Rodrigo?
Probably, I would love to know what is the proper antiviral treatment. I think we still need that. We have developed so much knowledge about other things, but we are still lacking on a proper antiviral treatment. So that's what I wish I knew, or I wish I know.
Let's hope that soon we have an answer for that. Dr. Shelton, what would you have liked to know before?
I think for me, it's, thinking back now and looking at how many months it feels like we've been in this. I wish I had appreciated that this would be a marathon, that this would be hard on my family and friends and for staff. And I think obviously the economic toll, it's all consuming. And I think early on, I certainly was part of this too. I ran in early thinking we would peak that day or the next day or the next day. And here we are many weeks later, still with patients, still talking about it. And I think it is important to, I wish I had maybe slowed down in the beginning and recognized that this would be a long course, a lot of Zoom meetings, and to maybe pace myself a little bit better.
Thank you so much. Doctora Regina, one thing you would have liked to know before?
I think you all are going to laugh about this. The thing I would have liked to know is how hard it was to work with full PPE.
Okay.
Just to get used to it, just to have I don't know, a little clue about that, because I think that's the hard part of everything, because it difficults a lot the communication with your colleagues. It makes you sweat, you feel so hot, you wanna rip it out. It's very hard. I think we should have been trained for that.
Okay. Dr. Bittner, one thing you would have liked to know before?
Sure. So there was so much anxiety and fear at the beginning of the pandemic, about risk to ourselves as healthcare providers and to our families, and so much isolation as a consequence. And I think one of the really amazing things that we've learned is that despite some of the fears that we've had, we've come to learn about safe practices, and we've kept ourselves and our families healthy for the most part. And we found, even though we're social distancing and that in one way isolation's necessary, we found new ways to connect. And I think that would have been very reassuring had we known that at the beginning.
Okay, well, great answer. Well, thank you so much for sharing your knowledge. For me, it's an honor having doctors from both Mexico and the United States sharing your knowledge and how each one of you is battling against this pandemic. We'll upload everything on YouTube, so you can watch yourself again if you want to, and everyone who is watching this right now. And thank you so much. If there is anything you would like to add, or maybe we can just make a pause here. No? Okay. Well, thank you and have a great day. And thank you a lot for your time.
Thank you.
Thank
you very much.
Goodbye.
Bye-bye.
Bye.